Orbital decompression is an operation or a series of operations where we effectively increase the space available for the tissues of the eye socket, and we tend to particularly use it for treatment of patients with thyroid eye disease or a subgroup of these patients. With thyroid eye disease, you effectively have too much tissue for the restricted space of the bony orbit. The bony orbit has 4 walls, and you can treat the excess tissue either by removing some of the tissue, like too much ice cream in the ice cream cone, or else you can expand the cone. And we tend here to use bone decompression, where we remove some of the walls of the eye socket, create more space to allow the tissues to settle back into the orbit. The number of walls you remove varies between 1 to up to 3, dependent on how severe the excess of tissue is, how far forward the eyes are, and also the reason for doing it. In most cases with orbital decompression, we will do it when the disease process is relatively quiet. So it's for rehabilitation, for making the patient look better, more comfortable, less prominent eyes. But occasionally we're forced to do it rather earlier in the disease. For example, if the eyesight is failing due to the pressure within the socket, we create more space, and we may do that whilst the disease is still quite active. And as I say, we grade the amount that we do. The approach to the surgery varies according to the number of walls you want to decompress. The commonest will be to create windows in the outer walls of the socket, which gives a moderate amount of decompression, and we base the incision in a small incision in the outer angle, about 1 centimetre, half an inch long, and it hides itself extremely well because it falls into the natural smile lines at the outer angle. Really is a fantastic approach. Very rarely will you see the incision after a couple of months. It'll have faded in. Occasionally we also use a different incision which doesn't involve skin at all, and it's just based at the inner angle, where we can reach the inner wall of the socket and part of the floor. And so whatever approach we use very well hidden incisions. It tends to be a highly successful operation if one does the right procedure, and so now we tend to tailor the number of walls we do according to the severity. Sometimes we will deliberately avoid doing too many walls at first, because originally we had some cases where you had over decompression. The eye became slightly too sunken, and now rather than have that, we'll tend to do one wall first, the outer wall, and if one later decides you need to do the inner wall, it's not a major problem because the inner angle incision is so easy, and you can grade the amount, and the results tend to be extremely good with a very low complication rate.
And how long does surgery last?
In general, one is talking about an hour on each side for the surgery plus the anaesthetic time. And in practical terms, from the patient's point of view, they should think about it as a few hours surgery, one night in hospital generally afterwards, and then you have the sort of post-operative effects such as swelling, occasionally double vision and things like that, which naturally impair your things you do. But in real terms, it's 1 day out of circulation for the person.
And can both eyes be operated on at the same time?
We used to do one side at a time, but then patients said, can I not get it over and done with? And typically now, if a patient requires 2 sides done, we'll happily do it. We know that the instance of visual loss, which would probably be the one reason for doing one eye at a time, is so low that patients say, no please, I prefer one anaesthetic, have it done, get back to my life that has been put on hold by the thyroid eye disease. So typically we'll do 2 sides, but if the patient says, no, I really either don't want to be padded on both sides because of claustrophobia or something like that, then we'll happily do one side and schedule the second side maybe a week or 2 later. So we very much listen to what the patient would like. It is major surgery, and most are not significant risks that'll lead to a long-term problem. As say, side effects typically are swelling. Infection is very rare, but could occur with any type of surgery, but really is very rare. It's less than 1%. Some complications would be irreversible. For example, if you lose vision. Now, it's very hard to estimate the risk of visual loss. We know that it's certainly less than 1 in 3,000 for a given eye, and therefore if you're doing 2 eyes, the chances of it occurring would be less than about 1 in 10 million for it to occur in 2 eyes. We've never known it to happen, but that's an estimated risk. It's certainly very, very low. Most other things, probably one of the most awkward things is double vision. In most cases that will be transient, and it's just due to a bit of swelling, in the same way if you twisted your ankle, it'd be stiff and not working very well. Doing surgery on the eye socket, the tissues get slightly swollen, stiff, and so you tend to get a little bit of double vision, particularly on extremes of gaze. Most people that'll settle down fairly quickly, within days or weeks, but some people will have had double vision before, and that may be slightly more troublesome, or might develop double vision after the surgery, and again that might require something done about it, either prisms fitted in the glasses to help them function. Occasionally, if it's very troublesome, the double vision might blur out one lens on the glasses to allow them to run round until it's stable, and occasionally requires squint surgery, but it is a minority of people who will finally require something done about double vision. Other complications or effects, some people may get a little bit of numbness, particularly of the cheek, because the nerve that gives feeling to the cheek, not movement, it doesn't affect movement, it's purely sensation to the cheek and the upper teeth. That nerve goes across the floor of the eye socket, and if you decompress the floor, the nerve often will say, "What's happened?" and stop working for a while. But typically that picks up in about over 95% of cases. But a few people will get permanent difference in sensation, not movement. And other complications are very rare. Occasionally you get sinusitis in the early days, but that's rare. And last of all, with outer wall decompression, you occasionally get a very slight wobble of the image, maybe in only about 1 to 2% of patients when they chew vigorously, because the muscle used with chewing sits next to that outer wall, and so if they really chew hard, they might notice a slight wobble. Very hard for you to see as an outsider, but they just perceive a very slight wobble. Doesn't tend to trouble them, but they report it and say, "I thought the wine was too strong," when they're having a pleasant dinner.